Hello everyone, welcome to another video in the Think Like a Medical Registrar series. Today we're talking about loss of consciousness. For those of you who don't know me, my name is Dr. Vishal Kumar. I am a medical registrar in the UK and I set up the Keen Medic YouTube channel and also keenmedic.com, where you can find my course and my book. So let's get started. Today we're going to be talking about the differential diagnosis of loss of consciousness, starting off with the main ones that you need to look out for, and I'm going to give you a way of thinking about the differential diagnosis as well, followed by the investigations, then the management and special considerations for loss of consciousness, and finally a summary because we're going to be covering a lot. So stay with me until the end. Right, let's get started. So the differential diagnosis. So I'm going to simplify things for you. Okay, so let's try and keep this simple because loss of consciousness is absolutely vast. It is humongous as a topic, and there are many differentials that can cause loss of consciousness. So I'm going to simplify it by breaking it down into parts of the body, okay? So top to bottom, that's what we're going to do. So we're going to start with the brain, then move on to the chest, then move on to the abdomen, okay? So keeping it nice and simple. So in every single section of the body, there are going to be differentials where I'm going to be bolding them, okay? So they will be in bold. These are the unmissable diagnoses that you have to think about every single time and be extremely cautious about making sure the patient does not have any of them, okay? So let's start off with the brain. The first thing is bleeding that can cause loss of consciousness, and particularly subarachnoid hemorrhage. Very much a fatal cause of bleeding. Now, I'm not saying this is the most common or a very common finding, but it is the most important one that you need to rule out when someone comes with loss of consciousness, especially if they've had a headache prior to the loss of consciousness. Okay, so subarachnoid hemorrhage followed by intracerebral hemorrhage of some kind. This may be spontaneous due to hypertension, anticoagulation, etc. Another thing is stroke. Now, normally stroke does not cause loss of consciousness, but depending on where the stroke is and the context of it, it can cause it. So do look out for that. The other things are things like infections in the brain. So these would be meningitis and encephalitis. Meningitis and encephalitis, again, don't typically cause loss of consciousness, but can cause loss of decreased GCS, okay, decreased consciousness itself, which may well present as loss of consciousness. This is particularly true for encephalitis. Now, these are the three that I want you to keep an eye on, okay, the ones that just pulsed. We'll come back to them in a minute. Seizures. Now, these are actually very common, and these are due to a number of different issues, okay? First and foremost, these can be due to epilepsy because a person may well be known to have seizures already, and they may have not had their medications or just be having increased seizure frequency of unknown cause. It may be due to alcohol, so alcohol induced, or because of withdrawal of alcohol, okay? Another thing is drugs. So drugs can be anti-epileptics commonly, or benzodiazepines. Induced or withdrawal can also cause seizures. Space-occupying lesions, so anything that occupies a part of the brain and compresses on surrounding structures can cause disturbances in neural connection and electrical activity within the brain parenchyma, and this can essentially lead to seizures, okay? So space-occupying lesions, these may well be things like malignancy, cancers, or it can even be things like big aneurysms or bleed, okay? Speaking of bleeding, the last thing, of course, is bleeding. So bleeding can present as seizures. So intracerebral hemorrhage can cause seizures. So if a person comes in with stroke-like symptoms and presents with seizures, you need to be thinking about whether this could be seizure due to epilepsy or a first seizure, or maybe it could be a bleeding. Okay. All right, so these are seizures. Raised intracranial pressure can also present as loss of consciousness. So raised intracranial pressure can again commonly occur due to space-occupying lesions, which again, as I said earlier, can be due to the same causes as seizures. So we've done the brain. That's the brain done. Okay, so let's move down towards the chest. In the chest, we're going to talk about the heart first and then the lungs. Okay, so nice and easy. The heart than the lungs. All right. So first of all, the heart. First and foremost, myocardial infarction, MI. So if a patient, especially if they have got risk factors for ischemic heart disease, presents suddenly with loss of consciousness, preceded by some kind of symptoms like chest pain, palpitations, sweating, vomiting, you should think about myocardial infarction and think about whether you might need further investigating. And arrhythmias can cause loss of consciousness, very much an important differential to rule out. Okay, so you would need things like ECGs, 24-hour ECGs, reveal devices. We'll come to investigations about these later. All right, so the other thing is aortic dissection. So aortic dissection, especially if it is an ascending dissection, can cause loss of consciousness. Or if it is a large acute dissection, can cause loss of consciousness because you will have hypovolemia because of the bleeding, okay? If it is an ascending dissection, which is classified as a Stanford type A, you should look this up if you don't know what that is. So type A dissection, then what can happen is it can tear towards the heart, and this can cause arrhythmias because of disturbances to the inferior wall or the AVN. All right, so other things that you should think about when it comes to the heart are more kind of structural issues, okay? So first of all, structural heart diseases like hypertrophic obstructive cardiomyopathy, HOCM as it is known. Now this is of course a genetic disorder which becomes symptomatic if patients exert themselves. Typically, it would be like a young 20-year-old footballer who suddenly dies on the pitch, okay, whilst running. So this is the kind of thing that you should look out for. So you should be thinking about family early death in their families with sudden cardiac death, okay? So that's a question you should be asking. Tamponade can very much cause loss of consciousness. But again, you know, this is the kind of thing where you would think about if the patient has had recent cardiac surgery or if they've had trauma to the chest. So these are more surgical things which you won't really see as a medical reg or in your PACES exam. Similarly, rupture can cause loss of consciousness, but the thing is, you know, with things like tamponade and rupture, they are so sudden and acute that you won't normally deal with them. It would go straight to the surgical team anyway. But let's say you had a patient with a recent ST elevation MI on CCU who has been treated, okay, and then suddenly they have loss of consciousness or suddenly they collapse hemodynamically. You could be dealing with a rupture, and if it is a rupture, then it needs urgent scanning, urgent diagnosis, urgent management, and cardiothoracic input. Okay, it's not something that you would be able to manage in your scope as a medical registrar. Okay, so that's the heart. Let's move on to the lungs then. The main thing, the single most important thing as medical registrars that you should be looking out for when someone comes in with loss of consciousness is pulmonary embolism. That's the biggest thing, okay? Especially, let's say, if they've had long-haul flights or other risk factors for venous thromboembolism, or let's say, you know, they have recently had a diagnosis of cancer, they've had chemotherapy, and then they come in with loss of consciousness, then pulmonary embolism should be right at the top of your differential. And that's the first thing you need to be ruling out. Followed by, of course, things like tension pneumothorax. Now, again, you know, pneumothorax has to be pretty large, pretty substantial for it to cause tension. And if it is a tension pneumothorax, then this should be dealt with urgently, quickly, with needle thoracocentesis, followed by a chest drain insertion. All right, so let's move on to the abdomen. In the abdomen, there's only really one thing that you should be thinking about, which can cause loss of consciousness, okay? Most other things like infections or space-occupying lesions don't usually cause loss of consciousness in the abdomen, all right? So the bleeding thing that you need to think about in the abdomen is always the aorta. So aortic aneurysm rupture, which can be large and sudden and catastrophic, or dissection, which can also be quite catastrophic, but it may not be as bad if it is away from the heart itself. But if it is a big dissection, then they can still bleed straight into the false lumen, and that can cause major issues. All right, so I hope that makes sense so far. Other things that you should think about, other differentials that are less important, except for one, okay? Hypoglycemia is probably the most important of the miscellaneous differential diagnoses. So hypoglycemia can be caused by drugs such as insulin and sulfonylureas, or it can be due to malnutrition. Hypoglycemia is something that you should rule out for every single patient coming in with loss of consciousness, okay? This is true for the acute take where you are admitting patients, and also for patients on the wards. Everyone, okay? So you need to make sure that a blood glucose is done and that hypoglycemia is ruled out, because this is it is a very common thing, which is also very easily reversible. And if you don't do it and the patient was found to have been hypoglycemic, this can be this can have very significant consequences for both the patient and yourself. All right, so postural hypotension is the other thing that you should be thinking about. This is common, but this is usually not catastrophic, which is why it's not bolded. Typically, it can be caused by autonomic neuropathy, most commonly due to uncontrolled diabetes. It can also be drug-induced, like some TB medications, for example, and chemotherapy medications can cause neuropathies that can cause postural hypotension. Vasovagal syncope is, of course, something that can happen in anyone, literally. Carotid sinus hypersensitivity happens when you turn the head and suddenly they collapse. Situational, typically micturition or cough. So when someone's passing urine or when they cough. Okay, so these are all other potential differentials that I've listed for you to know, but these are less important for you to rule out. So the patient may well have one of these, but the most important things are the bolded ones. Okay, so we'll be returning to the bolded ones later in the presentations. So make sure you stay with me until that point. So investigations now. So investigations need to be in a similar way that we have talked about the unmissable diagnoses, okay? So you need to investigate the most important things that will kill the patient first, and then move on to the others. I'm now going to give you a list of investigations that you should always think about. This will vary from patient to patient, so you need to be considering each of them for every patient, but not necessarily do every single one of them for every single patient, because some of them may be less important than others, okay? It's all about context, it's all about situational awareness, okay? About using your clinical acumen. All right, so let's get started. A good history is everything. So you need to start off with the history, because that will point you in the right direction about how you should be investigating. Without a good history, you can throw a million investigations at someone and not find anything. Standard blood tests, because anemia is very much a cause of loss of consciousness. Significant anemia does cause loss of consciousness, so you don't want to be missing something that is common and easily reversible. Troponin for myocardial infarction, so you should think about this, especially if the risk factors are high. Speaking of risk factors, D-dimer, if the chances of someone having a pulmonary embolism is low, then you should perform a D-dimer. So the way you score it would be using a Wells score, okay? Wells score for pulmonary embolism should be used, and then if they score low, then you should perform a D-dimer test on their blood test to rule out pulmonary embolism. It's not a ruling in test, okay? Because a D-dimer can be raised due to a million causes, okay? It doesn't mean anything when it's raised. But what it does mean is that, well, typically you would have to proceed with a CT pulmonary angiogram if you have a raised D-dimer. So that's the trouble with it. Okay, so ECG is by default something that you need for every single person that comes in with loss of consciousness, without a doubt. Similarly, blood sugar as well. Lying and standing blood pressure, not everyone may necessarily, you may not need this for every single person, but this is something you should consider for everyone. And of course, CT head, same principles apply. Then you proceed to everything else, okay? So the first slide that we have just covered are all the basics. and then you proceed to everything else that will be a bit more specialized, a bit less common, but still important. Okay, so these are things like CT aortogram to look at CT as to look for evidence of aortic dissection, aortic aneurysm rupture. And echocardiogram. So echocardiogram would and should be more commonly performed for patients with loss of consciousness, because this will look at evidence of structural heart disease. By structural heart disease, I mean things like hypertrophic obstructive cardiomyopathy, HOCM, and also things like aortic stenosis, which, if severe enough, can cause loss of consciousness, and that would be an indication for you to refer the patient to the cardiology team for intervention. All right, 24-hour ECGs should be considered to look for evidence of arrhythmias. I've written 24-hour ECGs, but what can happen is patients may have dysarrhythmias outside of a 24-hour period. So in this case, you should be referring to the cardiology team, because they would consider 7-day monitors or even reveal devices. All right, and another thing that you should think about is lumbar puncture, especially if they had prodromal symptoms of a headache, visual disturbances, and if the headache is particularly severe, because you need to rule out subarachnoid hemorrhage and by looking at xanthochromia. Okay, so that's lumbar puncture. CT head with contrast or MRI head to look for evidence of things like space-occupying lesions, malignancies. And of course, after doing all of this, you would also consider things like cardiology or neurology input, because they are the specialists that deal with loss of consciousness of unknown origin. They will investigate further and try and find out the underlying diagnoses. You may not necessarily have the authority or the expertise or the facilities to put in a reveal device, right? So that's why you need to ask for help from cardiology and neurology. Okay, so how do you manage? So in terms of management, this depends entirely on the cause, again, presuming you have found the cause. So this is the attitude to the overall approach, because that's what matters here. You need the right attitude to approach this right and get this right, okay? The management is going to be vast, and it's going to only end when you find a cause, okay? So it could go on for weeks and months and years for all you know. So what you need to do is do the acute management, make sure the patient does not have any of the life-threatening issues, and then what you should do is look out for anything that's common. And if you've done these two, then you should by all means refer them on to the cardiology and the neurology team. Okay, you should seek help. Remember, you're not on your own, so you should not be taking all the responsibility and not be safe. Be safe. If you've done all of points number 1 and 2, as we have covered earlier, by all the relevant history, investigations, then you should seek help and refer to cardiology and neurology for further investigation and management. Okay, so certain special considerations you should think about when someone has had loss of consciousness of unknown cause is the implications on their life. This is especially for driving, okay? So let's assume you have someone. Now, if they are driving and you don't have a cause, then suddenly they can pass out whilst they're driving on the motorway and cause a major accident, okay? And cause cost to their own lives and the lives of those around them. So this is a huge issue, which is why you have to ask them to inform the DVLA. Okay, in the UK, and it is the patient's responsibility to inform the DVLA and not drive until they've received clearance from the DVLA. And in terms of the job, you need to find out what they do as work. If they operate heavy machinery, etc., then they would not be suited until a cause is found and an intervention has been put in place. Similarly for the driving things as well, okay? The most important slide of the entire presentation, so pay attention because these things kill, okay? We've covered them earlier but I'm coming back to them because these things will kill and they may well cost you your exam if you don't cover these, okay? And look out for these. First and foremost, subarachnoid hemorrhage, stroke, myocardial infarction, arrhythmias, structural heart diseases like hypertrophic obstructive cardiomyopathies, aortic dissection, pulmonary embolism, and hypoglycemia, which is severe. Okay, so these 8 things are your holy grail when it comes to loss of consciousness. You have to always, without any exception, be looking for all of these every single time. Okay. All right, so let's talk about what is actually common then. Now we've talked about the life-threatening things. So what is actually common that you see on a day-to-day take, on the acute take? You may well see a lot of the life-threatening things, and you do. You know, I still see a lot of life-threatening causes of loss of consciousness on a day-to-day basis as the medical registrar on call. But I also see these kind of things, which are very, very common. Okay, so these are things like postural hypotension, vasovagal syncope, alcohol-induced or withdrawal seizures, accidental falls with no loss of consciousness. Okay, so what is often mixed up is that, you know, patients will come in with accidental falls with no syncope whatsoever. They will just have tripped over and fallen with no loss of consciousness, and that will be reported to the healthcare professionals as the patient as collapse or loss of consciousness, when it's not necessarily the case. Okay, so that's why a clear history is absolutely vital. All right, so let's do a quick summary because we've covered a lot in this video. So let's start off. So this is a very common presentation. Loss of consciousness is very common and it's very important. A good history goes a long way and it will point you in the right direction. So make sure you get all the important questions out of the way. Investigate appropriately after the history and rule out the life-threatening stuff first. Okay, that is your very first priority. And then do all the basics for the common stuff, and then ask for help. Okay, very much in your right to do that. Make sure you're safe. Find a system that works for you. So you may well find that doing what I did earlier, breaking it down in terms of the brain, the chest, and the abdomen works for you. Or you may find something that is completely entirely different. It's entirely up to you, as long as you do the important stuff of ruling out the life-threatening things. And don't forget about driving. Okay, make sure you ask them about it. Alright guys, so I hope you found that useful. If you are a keen learner and want to learn about strategies for MRCP PACES, make sure you check out my book, which is available on Kindle and also the paperback forms, and my course as well. Both of these will be linked in the description down below, so make sure you check them out. I'll see you in the next video, guys.